And we're back. Good morning. It is Wednesday, April 1st. Don't believe a thing you hear today. I'm not creative enough to come up with anything to fool anybody. Had clinical yesterday. Another good clinical. I got a lot of steps in. I finished the day with 17,000 steps. So that was a pretty active day. I did get some really good feedback from the staff. One of the managers at the med surge unit. They call it a medical care unit, not a med surge unit. I stopped in to say thank you and tell him his staff and his nurses and everybody was just wonderful welcoming my students in. And he said, "Yeah, you're one of the best clinical instructors we've seen through here. You're really engaged. You teach them. I've heard you hold court on several topics." He goes, "A lot of times they just kind of like drop them off and let them do their own thing." So I'm like, "Oh, well, that's good to know." And I did ask my students for some feedback. I said, "Look, this is new to me. I'm trying to make this the best experience that you can have. So if there's something I can do to make it better, please let me know." So, and they said, "We think you're doing a great job." Now they do want some more hands-on stuff, but we always want more hands-on stuff. So IVs and all the bedside procedures. So we're working on it. That's me, Gary in the ER. I mean, your own theme song. Like, how great is that? Typically use that on the podcast. I haven't done a podcast episode in a while, but we're working on that. Let's see, what are we gonna have for our background music today? Oh, I know. We're going 90s grunge. We did some 2000s pop punk, but we're going back to my roots. So what's new? Good morning. Where are you from? Oh, don't be afraid. Say hi. Say good morning. Here we go. Scrubs. We need to talk about Scrubs. Favorite brands, because mine are all old. Like most of mine are like 10 years old. I think the newest one I have is like 5 years old, and that was a free pair of figs that I got from my travel agency. Oh, good grief! No, don't want to co-host. There we go. Doing some little grunge. That's my wheelhouse. Happy Wednesday. Good morning, Juliana. Welcome in. Cindy, welcome in. From an ED night shift nurse who got off early. Oh, that's always nice. So I guess it wasn't too terrible, or maybe day shift came in and relieved you early. No, day shift would never come in early to relieve you. No, I'm just kidding. We do have some that will do that. How was your shift? I'm off until like next Wednesday, like a week from now. I don't go back for another week, which is nice. Low census. See, one of the things of the VA is we don't get sent home for low census, and that's really nice. Juliana says, "I haven't been in here in a minute." Yeah, I haven't seen you in a while. I know, April already? That just means I'm 1 month closer to being able to decorate for Christmas. So, yeah, I'm super excited about that. We're also simulcasting over here on this one. I can't say it out loud. TikTok doesn't like that. But yeah, the really nice thing about doing a live here is that when you're done, it will automatically create really good clips. Like it pulls from that and creates like 6 or 7 really good clips that you can then share out. And I thought that was really cool. The problem I didn't know is that I wasn't centered. And so like my face is like cut off. Good morning, Ames. Welcome in. Ames, we're simulcasting over here too. It makes really good clips, makes it easy to share stuff. TikTok's clips are very promotion heavy, like showing all the things that people did for you, and the over here focuses more on the content. So shareable clips when you're talking about a particular subject. So speaking of which, yesterday was a great learning opportunity for my students. Every clinical is, but Ames, I got to hold court on so many cool topics. And Ames, I need to ask you, for you nurses out there, I need your input on something. So my goal for the students yesterday, one, like I had to make sure I watched them do a set of vitals and do a manual blood pressure. That was part of our checkoff. So we did that. I had to watch them wash their hands, which is part of their checkoff. We did all that early and got that out of the way. But here's the thing. At the end of the day, what I told them is during the day, I want you to assess a patient. I don't need to be there to see it. I need you to assess them, listen to heart and lungs. I need you to ask them history, basic things. I don't need the full med rec. Just give me like 5 medications that they take and have an idea of what they mean. And then they present that patient at the end of clinical and post conference as almost as if they're handing off to the next nurse. And they did a great job. And so I would listen to this, and this is only their second clinical. They're first semester students. They haven't had pharmacology, or they've had very little pharmacology. So I don't expect a whole bunch. This is really just to kind of get them comfortable in presenting a patient. And so while they were giving their presentations, a couple of times, whenever they said something, I was like, "Ooh, I'm gonna talk about that." I'd write a little note down. So one of the things that I heard was, what the plan was for patients, and one of the things they talked about was being on heparin injections, and I'm like, okay, but then I heard the student say, I gave IM heparin, and I was like, so I wrote that down. IM. I'm sure she meant sub Q. That's fine. We'll talk about it. So I said, now, after she was done, I said, now you mentioned that you gave IM heparin, or not, that your nurse gave IM heparin. Did you mean sub Q? And she goes, no, the nurse even asked, and they said, no, it was IM heparin. And I kind of gave this look like, we're going to look that up. I don't want to say that that's not a thing because I've been proven wrong, but we're going to look that up because that's not something I'm familiar with. So I look it up, and I look in our nursing, medication book, and it doesn't list IM as any type of delivery for heparin. It is either IV or sub Q. And then the next question was, well, what did they administer with it? Do you remember what kind of needle it was? And they said it was the orange one that they use for insulin. I said, okay, that definitely should not be given IM. So that was an interesting exchange. And that really kind of solidified my earlier pre-conference instructions to them was, trust but verify. Just because someone's telling you something doesn't mean that is the right way to do it. Just because somebody with more experience than you tells you something doesn't mean that's the right way to do it. And so I said, if that had been me, and I explained that I've been in this position before, if that had been me, I'd be calling pharmacy and asking pharmacy, hey, I've been told to give this IM, and I don't see that anywhere listed as an option. Can you advise further? And then if they said, oh, sure, go ahead and give it IM, I'm going to say, great. Can I have your first and last name, please? Because I'm going to put that in my chart that the pharmacist said I can do this. And then I also said, if you still don't feel comfortable administering medication, you can say no, and you can talk to somebody about it. Oh, yeah. So anyway, that was it was one of those things, like, my first instinct was like, no, that's not a thing. But then I was like, no, we're gonna look this up because I have said stuff like that and then looked it up and go, oh my gosh, yes, you absolutely can. So I was able to take a step back. We looked it up, and I was like, I'm not seeing it. I don't think that's a thing. I think somebody told you wrong, or somebody told that nurse wrong. That's right. And I do that. When I you know, see something that doesn't mesh with what I'm taught or what I'm reading, and yet I still get approval from somebody like pharmacy, I document. Pharmacist John Smith said it was okay to run this wide open or push it fast. But, I try to give like little nuggets of wisdom that will stay with them. And one of the things that I tell them right off the bat is there's only one medication that you should ever push fast. Outside of that, you should go slow with pretty much everything. And I mean, that's if you adhere to that, you'll be okay. Adenosine's the only thing you push fast. Everything else you do, there's no reason to push anything fast. I said, when in doubt, go slow. That's right. I've been wrong before. So let's look that up. But that doesn't feel right. That's kind of I have a version of that. But yes, I don't want to say no. That's not my experience, but we're gonna look it up just to make sure. Pressurized heparin. Oh, are you talking about like Lovenox, like the low weight molecular heparin? We've got those those have that, like, auto inject thing that scares the bejesus out of you every time. You're waiting for the click and like, "Oh, there's the click." Good morning, UC Mystic. Welcome in. Angel Ash Memories, thank you for the daily heart me. I appreciate that. Uh-oh. Is the music doing the thing again? No music. Oh, unplug. It's that daggone TikTok. When people try to co-host with me, every time they do that, it kicks off my audio for some reason. Yeah, that's what it is. So when I like people from like India and Pakistan will be like invite me to co-host, and I wish there was a way to like turn that off, but it's only after they do it like 5 times that I have the option to turn it off. But it sounds like it's back. All right, cool. Bobby, thanks for sharing out the live. Pickle451, thanks for the follow. I appreciate that. Legal Nurse Leads, thank you for letting me know what was going on. Appreciate you guys. It was weird. I tried to add some other folks as moderators, but it won't let me. It won't show me that they're even an option. So I don't know what the requirements are. Like I follow them, they follow me, but yeah. And we got, Pearl Jam in the background. We got to have that. Got to have that. I'm trying to think what else did we do? We had 2 more transesophageal echocardiograms without cardioversion, so that was good. What else? Amanda Donnell, good morning. Thanks for sharing out the live. I appreciate you. Would 9 years of nursing mean you are a charge nurse? No. There are nurses that have been bedside nurses for a long time that are not charge nurses. Charge nurses, um, usually management identifies people that they feel would be a good charge nurse that can kind of run the department. Not all nurses want to do that. Not all nurses, have the mentality to do that. Some prefer just take their assignment and not worry about it. I mean, after 9 years, you should have the skill set to do it, but not everybody has the mentality to do it. Good morning, Go Live Vegas. Welcome in. Early out there. Yeah, don't forget to tap that screen. I think my new bestie Asia and Michelle closed out my gallery. It hasn't been reset yet, so but yeah, tap that screen, that helps. Have you ever no. Have I ever sat in on an orchiotomy? No, I've not. I don't work in the OR, so I'm not privy to those kind of things. My students have literally seen more procedures than I have. They are yeah, if you do lives on a regular basis, I recommend signing with TikTok agency Go Live Vegas. They're great. They're gonna give you more information. They're gonna give you tips and, help promote you, and there's no cost involved with it. They don't pressure you. It's just an added layer of security and protection. So, Aaron and his crew are really good people. He's also Gen X, so, we can relate. Let's see, legal nurse leads. Then those of us who are only 18 months into the CVICU got told, "Hey, oh wow, they gave you 18 months? I was 6 months into my nursing career before I was made charge nurse." I don't understand the obsession with having music on in the back. It's a personal preference. It's not an obsession. I dig grunge music. I like listening to it. It gives me something to talk about. I mean, if it bothers you, I mean, you can go to someone else's live. That's fine. I won't be offended. Have you ever taken care of a patient with a bile leak 6 weeks after gallbladder removal? Well, as I understand it, the gallbladder, I mean, it's just the gallbladder is just a storage container for the bile. I mean, after gallbladder's taken out, the bile is just going to continuously drain into the intestines. That's the way I understand it. So I don't know unless it's leaking outside of what it's normally supposed to go down. So I don't know. You see a lot of heart attacks coming in? Yeah, we get a lot of that. What they tell you it depends. Not all presentations for heart attacks are the same. Some it's like my stomach's upset, I'm short of breath. Some, not all of them are that crushing chest pain that, that people you see on TV and stuff like that. Especially in women. Women can be very vague. Their symptoms are very vague. So you got to be really careful. Any weird symptoms from a female patient is a heart attack until proven otherwise. Good morning, Lex Wex. Welcome in. Cecilia, is there such a thing as an opioid-free pain medication? Sure. Yeah, there's lots of opioid-free pain relievers. We call analgesics. There's Tylenol, there's Toradol, ibuprofen. Now, are they as effective? Typically not, but it depends on what's going on. There are some things like migraines, opioids will not do anything for a migraine. Marquette, good morning from Georgia, EMT. Should I apply to be a tech in the ER? Yeah, if you want to. It's a lot of good experience. Any CRPS advice? Oh, no, I don't have any CRPS. See, I saw that, and CPRS is our charting software that we use. So I was really confused at first. I'm like, I'm pretty good. I'm like a super user of that, but CRPS, no, I would have to look that up. I feel like I have to look that up every time. And when I see it, I'll go, "Oh, yeah, that's what it is." So, I mean, like, yeah, if the music bothers people, I mean, let me know. I can turn it down. I just think sometimes it helps fill the space. So, is it CRPS? Oh, complex regional pain syndrome. That's right. I don't have any advice on that. We have pain clinics that manage that. I work in an ER. We don't typically manage patients like that. They have their own pain management plan. On par for women to be vague even during an MI. Right. Yeah, like, they just be like, "Oh, I feel funny. I don't feel right," or "My stomach hurts," or "My stomach is upset." And then you're like, "Oh, guess because 'cause you're having a massive MI. Any chest pain?" "No, not really." So, Dan K, I'm labeled as a drug seeker because I asked for Imitrex. Imitrex isn't a controlled substance. How can I have this removed? You should be able to request your records, and you should be able to request, inaccurate things to be removed from your records. You'd have to go to whatever facility that you went to. You'd have to go to their medical records office and ask for them, and then request that ask for, like, I don't know how the other hospitals do it, but you can ask for a chart correction form or to submit a request to remove something from your record. But there is an avenue to do that. It just depends on which hospital you went to. They have their own system. But yeah, we have a way to do that. Yoo-hoo, aspirated. See, I can't hear that. I think Frozen. Yoo-hoo. Aspiration during surgery. Oh, that's not good. Well, you're supposed to be that's why you're MPO before surgery, so you don't aspirate, but I guess it's still possible. I'm slinging pills to pay the bills. Welcome in. Good morning. Haven't seen you in a hot minute. How are things? Do I know any super good gastroenterologists? Well, I mean, I like mine, but it's probably not anywhere near you. Stomach pain for 17 years? Oh, goodness. Yeah, I wish I had a better answer for you. Is elevated SGPT means possible? That alone, not necessarily. I mean, you need a full battery of tests and, if there's concern, you need to talk with your GI doctor. Slinging pills is 100 what is that, 100 minutes? Oh, very cool. Chris, I had 77-year-old woman come in with a nosebleed, epistaxis for 2 days, minor flank pain, full-blown STEMI. Of course, why not? Mm. Now, see, I wouldn't have thought that. Nosebleed, I would thought hypertension, maybe like she's really hypertensive, but yeah, that's one of those things, you just never know. So basically, any female that comes in is gonna get like a EKG. CC, thanks for the follow. Appreciate that. Don't forget to tap that screen. Christina Owens, thank you for the daily heart me. I appreciate that. What EHR do you use? It's one the federal government bought in like 1963 called CPRS. Do you do extra courses for ER? Not extra courses. There's some certifications that they're going to want you to have if you work in the ER as a nurse. As a nurse, they're going to want you to have TNCC, which is a trauma course. They're going to want you to have ACLS for sure. And then they're also going to want you to have ESI, which is the Emergency Severity Index. That's how we triage patients. They're going to want you to have PALS, which is Pediatric Advanced Life Support. They're going to want you to have EMPC, which is another pediatric like critical care course. So there's a lot of things that they're going to want you to have before they're going to turn you loose to do everything in the ER. You can start in the ER as a nurse without any of those things, but they're going to want you to have those things. And if you want to work trauma base, you have to have TNCC. If you want to work triage, you got to have ESI. And typically, you're going to need at least 1 year of experience in the ER before they will let you do either one of those things, trauma or triage. How bad is kratom? It's bad. It's really bad. Asking an ER nurse about stomach pain for 17 years. I don't know what that is. Oh, I see what you're saying. Yeah. Bianca, bad toothache. I don't know. That's random. I like Epic. Now, where I'm a clinical instructor, the hospital there uses Epic, although we're not actually charting yet. I have no way to get, like, I had to go through all the training of Epic, but I actually don't have a badge. I don't have any way to access Epic, not patient records. I can do like the training version of it, but we're not there yet. I think I have to teach level 2 in order to get access to that where we're actually charting. We're really focusing on basic things like assessments, CNA type stuff like ambulating patients, bed baths, changing them, that kind of thing, manual blood pressures. Now we are starting to branch out into medication administration, but one of the things I tell them is until you know what that medication does and why you're giving it, don't give it. You need to know what it's for. What's the schooling like for an ER nurse? All nurses go through the same essential training. It is basically just preparing you to be a safe nurse. Depending on the specialty that you go into after graduation, will determine what additional education you need. But in terms of collegiate education, that is pretty standardized. So, and we all have, whether you are an associate degree nurse or a bachelor degree nurse, you still have to take the same licensing exam, which is the NCLEX. And then once you do that, then you can apply for your state license or the compact state license. Then, depending on where you go, like if you go to ICU, they have critical care courses for that. You can get a CCRN, which is a critical care, a certified critical care registered nurse. If you go ER, you can go certified emergency nurse. And there's all different acronyms that you can add to your name that they will usually pay for you to do. Our organization bought into Epic, so we get to test all the fun early. Oh, that's cool. You'll like Epic. I mean, especially you come from an older system. Like Meditech's pretty bad. Ours is worse than Meditech. Now, that being said, the VA is slowly rolling out Cerner across various VAs. We are not one of them. Hopefully, we'll get that because I've used Cerner. It's like a poor man's Epic. It's okay. It's way better than what we're using now. So I welcome the change because we still free type everything. There's very little checkbox stuff. Like you literally just keep a flow, like, I don't know, 11, 10, place 20 gauge IV. Oh, here we go again. Oh, it's so annoying. I'm gonna have to do it again. Oh, all right. I wish there was a way to like permanently disable that, but you can't. So for those of you that are on Substack, which is probably nobody, I'm using a different microphone for Substack, so it shouldn't affect that. But when somebody invites me to co-host, which I can't control, it basically bumps my audio. I have to reset everything, and it irritates me. So yes, we're over on Substack as well. I'm going to say it out loud. I don't care. Let me think. What else? What else did we see yesterday? There was no like biopsies. We did a lot of discharges. I think there were like 4 discharges yesterday before we left at 3. That's unusual. They got experience. It's funny how excited students it's funny how students get excited about what we consider menial tasks. For example, pulling an IV is a mundane task for an experienced nurse. My nursing students were like chomping at the bit to pull out an IV. And it's just, I don't know, it's refreshing to see that level of excitement for something that we who have been in it for a while don't think anything about. So, and like in fact, some of their goals, like they have to do a self eval after the class, after the clinical, and there were at least 2 of them that said, "My goal for next clinical is to remove an IV, not to start an IV. They're all terrified of doing that. And there's not a lot of opportunity to start IVs on a medical surgical unit because they already have established IVs, and the hospital has a VAT or a vascular access team. Yes. So I have a couple bags of fluids that are expired that we set aside for training. I am going to bring those in, and teach them how to spike a bag. Let's see, that guy's a combat medic. Thank you for your service. Big props to all y'all in the ER. I can yell and smack my patient. You know, I think, if I were young enough to join the military, I might do it just to be able to do that. I work with vets who are now nurses, and they miss being able to do that as medics. It's like, "Yeah, I can't do that now. It's frowned upon." Have you seen a case of pandas pants? I no, I don't even I'd have to look that up. Do re mi, I don't even know what that is. And when does our VA go live? I have no idea. I don't think we're even on the roster yet, like, to get it. It's gonna be I'll probably be close to retirement, and then Cerner will be, like, 20 versions ahead of the one that we're using. As MAs in my practice, we do IVs because we give vitamin infusions. Yeah, I mean, we have techs that can start IVs. Yeah, so I mean, we in the where I'm doing clinical, we just don't they all have IVs. Like they came to us with IVs or midlines, and we haven't had many opportunities to start or even look for. There was only one patient in the first clinical that needed ultrasound IV, and she was like, there was nothing I could do, not without ultrasound, and I'm not allowed to use ultrasound in that facility. Not yet. I'm working on it. But, I will say, the folks there seem I mean, it's a busy unit, but I feel like most people seem to like working there. I've run into a lot of people I used to work with years ago, and they seem very happy there. So that made me feel better. Justin, good morning. Thanks for the daily heart me. I appreciate you, man. Welcome in. Uh, ED Mandel. No, I do not. Ed. See, I saw ED and I think emergency department. Ed Mandel. Sorry. I don't work in a trauma center anymore. I came from a level one trauma center to where I work now. Kevin's new. Welcome in, Kevin. Well, I don't know. I wouldn't have go that far. I will say good morning, Holly. Thanks for the daily corgi. I appreciate that. Miss Lady B, D Lady B. Thank you very much for the follow. This hospital uses those Moxie robots, and literally the only thing that they do is bring trays. $12,000 a month to rent it to bring a late tray. I feel like that's a lot of money to bring a tray. I think they said, and this is a weird thing, they can also send blood. I'm assuming there's a different drawer for that you can't put that in the same drawer that the food came in, but it's still like if you can't tube something, if it's a glass file, you can't tube it to the lab, you can send that Moxie up there. It moves pretty slow. It looks really cool, but I feel like that's a lot of money for very little functionality, right? 12,000 a year to rent that thing? Is it 12,000 a year or 12,000 a month? I don't know. I hope it's not 12,000 a month. That'd be absurd. I came from level 1 trauma to the VA also, culture shock. Yeah, it's better for my mental health. I'll tell you that. Now, see, I did my clinical and I did the Valor program, and I don't know if y'all have the Valor program. I think it's a nationwide program. It's now VA STEP. It's not the Valor anymore, but I did that, so I was familiar with this VA, and they knew me too because I spent a year there working there. So it was kinda like a homecoming. A lot of the people that I worked with when I was a student were still there and are close to retirement now. What do you think about SI or mental health patients that come in? That's what we're there for. As somebody who has dealt with that personally, it hits close to home, and I have been in those dark places before, and so if they are coming in, that's a good sign. They're coming in to get help. That means they didn't go through with it, and they came to us to get help, and we are gonna give them help. And we have an inpatient, um, psych ward that will get them in and keep them safe. And Wilson, thanks for the follow, appreciate that. Slanging pills. I laugh every time I see that. I like the slanging. Thanks for the roses. I appreciate that. Well, let's see. Oh, thanks for the greeting heart. Very cool. Yeah, so the Moxies are they're they're kinda cool to look at, but I just think, "Man, that's a lot of money." I mean, to bring a tray, you couldn't spare one person to bring a tray? Now, I mean, Jennifer says they've got the robots that bring the trays and linens, they stop in front of the office doors and block the exit. Yeah, it's not what you want. These are pretty good, like, if you step in front of it, it'll stop and, like, just go around you. So it's got like, the sensors and everything. Let AMT students practice IVs on me. 18 in the left and right hands and AC blue in both hands. Oh my gosh. Yeah, I was thinking I've got really good veins. My students are like super jazzed about trying to learn, and there aren't a lot of opportunities. So I was thinking about maybe letting them try on me. I don't mind. I've let them do it before. It would have to be, I don't know. I mean, they got to learn sometimes, right? And it doesn't bother me. Like needles don't bother me at all. Patient complained of chest pain during open heart surgery. Well, they're talking to you during the surgery, that's a problem. I'd have to have a conversation with the anesthesiologist. Kelsey Kohlberg, new to the lives, welcome in. Kelsey, my name's Gary. I live stream most weekday mornings around 6:30, depending on what the kid's schedule is. But yes, usually 6:30 in the morning, I usually do live stream. We're going extra long today because the kids are out of school for uh, Easter break or spring break. And then I don't run rescue until 10, so I don't have to go to work today. I am doing good. Thanks for the follow. I appreciate that. Thank you very much. I live stream most weekday mornings, and the last weekend I did the same thing around 6:30 on Saturday and Sunday. How do they choose an IV? How do I find where I'm going to place an IV? Wherever the vein is. That's what I do. Wherever the vein is. So I will put on a tourniquet and I will just kind of look. I don't need them to squeeze their hand. That I don't do any of that. That's not necessary for me. And then I just feel. I feel more than look, because a lot of times when you've been doing it for a while, you'll be able to feel it. You won't always be able to see it, but you can feel it. And then I find the best possible site. If I don't see something I like on one arm, I go to the other unless they have some type of limb alert, whether it's they had lymph nodes removed, or if they, you know, um, if they had a mastectomy, or if they have dialysis, then you can't use one arm, so you got to use the other one. I can also do ultrasound IV. So if I don't see something I like, I can just use ultrasound. I have a story about an IV I just had to get. Let's see. UC Mystic couldn't work trauma, experienced trauma one peds event. Yeah, I get that. I've seen that too. And that, yeah, I don't like I can't do peds. I don't have the mental strength to do that. How do you cope with the horrible things you witness or hear? Therapy. Get a good therapist. Find some good hobbies. This is my hobby, live streaming. I used to be a radio DJ and television news anchor and reporter, so being on TV and talking, that's kinda like my therapy, part of my therapy. Before you know it, we will have iRobots as providers. I mean, I don't know how soon that will be, but yeah, we're heading that way. They're already using AI to help guide clinical decisions, which is it's supposed to be an adjunct to clinical decision making. It's not supposed to replace it. But in some cases, the AI is getting pretty smart at detecting things, particularly like with breast cancer identification. The early results show that AI can detect breast cancer like 5 years before a human radiologist could. I mean, that's great news, but I think radiologists are kind of nervous. I've seen some of them post like, "Yeah, our jobs will be the first to go." But I would not trust a total AI interpretation. I still want human eyes to be on that to confirm. Jennifer Butterlife, I let them practice on me. You let a fellow nurse poke you 7 times because she needed 1 win. I agree. I don't know if I'd go 7 times, but I think I'm gonna let them practice on me. Now I do have like 2 that already have experience, so that's only 7, that I think have no experience. Starseed floor, it's in the AC. That's where you go. It's in the AC. That's an ER nurse response there. All right, I'm trying to catch up here. JDN, yo, I'm an EM doc. Couldn't do anything without you guys. Oh man, appreciate that. Yeah, it goes both ways, right? Like we're a team. I got your back, you got my back. Ellie, good morning. Addie says I feel the same way. Rose, my son's an ER nurse in Arizona. He loves it. Good. I'm glad. I love being an ER nurse. I can't imagine doing any other bedside nursing. I've done other bedside nursing. I don't think I could leave the ER. If I did, it would be for something like vascular access. Emergency medicine was ranked one of the top AI resistant jobs. Cool. Yeah, I imagine that's going to be pretty difficult to replace. Like I said, I think radiology would be probably the first thing to get booted. Or no, you cannot drink. You can't drink propofol. No, that's definitely one. You shouldn't even have access to it. I said AI was going to replace us techs in the pharmacy, and we already have a robot, but we have to fix it all the time. Yes, I've heard that too. One hospital had those Moxies, but they kept falling down steps, and they had to have like a human attendant with them to make sure they didn't do things they weren't supposed to do. And so they just like, this is costing us more money than it's worth. So they canceled the contract. And I was like, yes. Croup an 8-month-old. How do I manage from home? Um, well, have you already been to see your pediatrician? Because that should be your first step. Um, because I think, isn't it? Oh gosh, I would say the first step is to go there. There might be some support. I mean, when they're that young, it's kind of limited to what they can do. I'm not a I don't work in pediatrics, so um, I would have to like look that up. So if there's any peds nurses in here, we can look it up and see what the treatment is. Oh my gosh. I love that the Cleveland Clinic is very like they have a lot of information, but my gosh, I got to scroll down like 100 subsections just to get to like how do you take care of it? Oh, for Pete's sake. I don't know. I'm gonna leave it up because like oh, that's it. Yes. Racemic epi is what I was thinking of. Nebulized breathing treatment and glucocorticoids. So that's why I was like, yeah, you probably need to go see your primary first. But if you go to the emergency room, that's definitely what we're doing. I don't know what they'll do if they send you home. Let's see. The Beanzo had a panic attack at work this morning. Oh, I'm sorry to hear that. I've had patients come in with that. That is, oof, that's rough. So I'm sorry for that. Let's see. Oh my gosh. Sorry, I am not gonna be able to keep up with all these. Yeah, cool air helps. Stand them in front of a freezer and let them breathe in cool air. I remember that one. Decadron. Oh, that reminds me, steroids. We were talking about pushing meds fast to my students, and I told them about what happens if you push dexamethasone too fast, and their eyes got really big. Now, the LPN who was in there, like she already knew, but yeah, if you push, who knows what happens if you push dexamethasone too fast? I mean, that's why you don't push anything but adenosine too fast. Should I be scared if I got the code? No, I've had all of them. I'm not scared of why? Why would you be scared? You're better protected. Leo, thanks for the follow. Appreciate that. Yeah, Nebs for home. I mean, because like our youngest has to do those, but we do albuterol and budesonide are the ones that we use at home. But yes, for you could probably do home Nebs. Oh, racemic epi is for stridor at rest. Croup would just be, according to the Cleveland Clinic, they said they would do the Cleveland Clinic says they will do epinephrine for croup. So that's where I'm pulling that information from. I feel like that's a pretty trustworthy source too. Like it wasn't Wikipedia. Why are so many nurses? Yeah, I don't know. I don't know. Yeah, I'm not trying to argue with anybody. Like I'm literally I feel like the Cleveland Clinic is a pretty reputable and I'm literally pulling from their sources. So like your personal preference on how you treat it, I guess is fine, but I don't deal with peds. I don't get pediatric patients, so that's not my specialty. I would have to refer to like Up to Date or something like that. And I just pulled up the Cleveland Clinic. So it just says specific croup medication, glucocorticoids, nebulized epinephrine. That is what they say. So why aren't nurses and doctors taught it? They are taught about it. They may not be experts in it. They may have learned about it. Like I learned about Addison's when we covered, renal. And then if I don't see it on a regular basis, that's not something that I deal with. That Addison's disease is not typically something somebody presents to the emergency department with. They may have that on their history, but that's not something that they're coming to the ER for. So if I don't see it on a regular basis, I'm not as familiar with it. But that's why we have Up to Date and other resources. Now, physicians, on the other hand, I feel like physicians probably get a pretty good dose of Addison's and renal function, and their depth of knowledge on pretty much any disease process is way more than nurses because they have a lot more schooling. So, but again, if they're not a renal doctor and they may not be as well versed in it as somebody who works in renal. I understand that it's frustrating sometimes when you have a disease process, and oftentimes you may be more familiar with it than your physician because you deal with it on a daily basis, and that can be frustrating when you don't feel like they're listening to you. I'm sorry. That is unfortunate, and it happens. So Goose asked, "What's the strangest thing I've found lodged inside someone?" I've never seen that before. Not as a nurse. I've not. I've seen other people post about it. I've heard stories about it, but I personally have never had a patient come in with a rectal foreign body. There's concerns about with the vax causing heart problems and blood clots. Yeah, but that's I mean any medication is going to have risks involved. Like I mean, any medication that you get prescribed, have you not seen the commercials? I mean, there's always terrible possible side effects. But like that kind of, like I understand that we need to address those concerns and alleviate them, but sometimes I think people come in here, they're trying to like gaslight other people into like, but what about this? Aren't you worried about this? So I don't know what your intention is, but if your intention is gaslight, I don't appreciate that. I am I understand there are risks involved with any medication. I take pantoprazole or yeah, I take pantoprazole, a proton pump inhibitor. There are concerns that may cause heart problems later in my life. But what stinks right now, what sucks right now if I stop taking it is the acid reflux and then I can't sleep and my throat is on fire. So if I can live like 30 to 50 years without pain in my esophagus, that can also lead to Barrett's esophagus. And then, like, maybe later in life, there's a small chance that I might develop some type of heart arrhythmia or heart problem that I'm sure there's another medication that can fix. I'm gonna take that medication because the risk to me is worth the benefit, right? So the benefits far outweigh the risks. So when people come in here and they start talking about, well, aren't you concerned that it might do this? Yeah, I'm concerned about a lot of things. I'd rather not have to take any medications, but that is not the world in which we live. The world in which we live means there are viruses out there. Scientists work really hard to develop vaccines to protect us, and I will continue to take them when they are approved. So there's that. You're going to get me up on a soapbox, and it's a pretty tall soapbox. Okay, V Bunny. I don't know what your comment is referencing. I'm not a gynecologist. I don't work with, female anatomy, so I don't have that answer for you. I understand you're asking the question again and again. I don't have an answer for you. Okay, yeah, and I understand, like, I have to balance that between educating people, but also I get gaslit a lot. Like, people come in here and wanna start a vaccine argument in here, and I'm not about doing that. I understand you're genuinely concerned, but if your family members are taking any medications, the risks involved with those medications are likely no different than the risk of getting a vaccine. Flu vaccine, RSV vaccines, all of them. Now I'm just gonna like shut my live down now because I said that so many times. All right, Leonard, have I watched The Pit? Yes, I'm all up to date on The Pit. New episode comes out tomorrow night, and the cliffhanger, which we all saw coming. Like if you've been watching the episodes, you know that you know how it was going to end. You know he was coming back, and I'm not going to spoil it for anybody. But it was a diabetic patient who signed out AMA who just left because he can't afford to be hospitalized. We all knew it was going to happen, and it happened. Nope, bars to bucks. Somebody ban him. I've got moderators in here. I got him. He's gone. Mute and block. Yeah, we don't tolerate that. So if you come in here and start saying that kind of stuff, you're banned. I mean, that's probably a bot anyway, but I don't play about that. Oh, there he goes. Zamora. Good morning, Zamora. Yep, got it. So I have like 3 moderators in here plus me. So and we will not hesitate. We're all on the same page. Step out of line and you're gone. I mean, it's probably a bot anyway. Yes, I think, The Pit is as close as you will get to a television drama that is going to accurately portray life in a level 1 trauma center. It is not 100% accurate. They take a lot of dramatic license, but yes, it is the most accurate. Any opinion on OMAD for resetting insulin resistance? No, I don't even know what OMAD is. I'm an emergency nurse. Like, that is my specialty. I don't have a specialty in endocrinology. So I would have to look that up and before I can form an educated opinion on that. Yes, Ashley. It drives it's exhausting. Every day is exhausting. And I get it at work too. Like I get patients that come in here and I had one accuse me I was gonna give a Toradol shot for pain, and he thought I was gonna secretly give him like legitimately said, "Are you giving me COVID vaccine?" And I'm like, "No." He goes, "'Cause I've heard they do that here." And I was like, "That is incorrect. That is illegal. A nurse would lose their license. I'm not losing my license for anybody." So, I'm giving you Toradol. Would you like to see me draw it up? I'll show you the vial. Well, how do I know you didn't mislabel the vial? Like, I can't even like, I get so mentally exhausted sometimes. Oh, you have Barrett's esophagus. I take apple cider vinegar instead of meds. That's maybe anecdotal, but apple cider vinegar is acidic, and I have read that that is not actually helpful. Now, you do you, but if you have diagnosed Barrett's esophagus, I would hope that you are talking to your GI doctor or ENT, whoever is managing this, and letting them know that you are using apple cider vinegar because I've seen physicians debunk that. But you do you. I can't tell you what to do. I would just hope that you're talking to your GI doctor or ENT before you do that. How often do you derive info from medical alert bracelets for patients who cannot speak? So as an EMT, like that's one of the things that I'm taught to look for, especially when you arrive on scene and there's nobody there to give you information and the patient's not responsive. So we check for alert necklaces, alert bracelets, um, depending on the severity, if it's a cardiac arrest type situation and we have limited resources, we can't really go through their phone. But if we have extra help, we can have somebody look in their phone to see if they can find any information. So I have, and that's a good segue. So I was sent one of the Hero Alert bracelets to try to demo, and my understanding is that this is designed for first responders, including like fire, police, EMS, and it has all your critical information on it in a bracelet that they can just like tap with like Bluetooth, like tap your phone to it, and it'll pop up all your information. So it arrived. I think I've got it here, right here. Yeah, well, let's open it up right now and we'll take a look. Oh no, this it's upstairs. This is a different package. That's a bummer, but I'll do it later. But anyway, that's a good thing. I have it on my phone. Like if you go to the medical alert information, like all my history is in there. But again, if it's a critical situation, I'm not sure they're gonna have time to look through my phone unless they have a lot of extra people. Having something on your wrist or your neck or your like around your neck would be good too. We got another Linz is in here. Welcome in, Linz. My name's Gary. I am a US based emergency room nurse, and we get a lot of folks from Australia in here. Let's see. I'm trying to catch up. If I don't respond, it's just because there's a lot of and I can't respond to all of them, which is a great problem to have. Lots of interaction in here. So we've got some EMS folks in here. Ames is a critical care nurse, former flight nurse, hopefully soon to be flight nurse again. So she's got a lot of good background. Been a nurse longer than me. Let's see. Olisi? I don't know how to pronounce that. I'm currently a student and I want to go to med school to become a doctor. In your opinion, what's it like? It's a grind. Well, hello. Appreciate that. Ames with a hat and mustache. Thank you. I had to like scroll down. I couldn't see who sent it. Yeah, so med students, it's a grind. Like they're busy all the time. I mean, it's a great career if you really want to help people, but I think it can also be very mentally, physically, emotionally exhausting. So, we definitely need more doctors, but I think you just have to factor in, like, you know, it's a commitment, like, it's once you're in and you've got that medical school debt, it's kinda hard to back out, like, you're in it, you gotta be in it and stay in it and ride it out, and it's gonna be challenging. I've seen a lot of exhausted, like, med school students. What? What was that? Manifesting. Ooh, what are we manifesting? Good vibes? I need good vibes. What personality would be most suited to become a doc? Because I'm really on the fence. It depends. I mean, there's all kinds of personalities. There's a specialty for everybody. Like if you are arrogant and like to boss people around, then surgery is probably for you. I'm just kidding. Not really. What's the worst ketone reading? Oh, I don't know. I couldn't even tell you. Manifesting all the good things. Sally, thanks for the follow. Appreciate that. Zamora's welcoming people in. Sandy was in Resus Bay, heart flipping. ER doctors and nurses really looked after me. Oh, you had AFib. Gotcha. Yeah, AFib is kind of like we deal with that pretty much every day. Lisa Magical was pre med and went to nursing to have more time with the patients. Yeah, we spend way more time. I think the issue, I think a lot of newer physicians or med students, residents have is how much time they have to spend charting and ordering things and they don't get to spend as much time with the patients. If you're on the fence, then it will be a really, really and now JDN is a physician, so I am not. I have I have seen many a resident in a room crying because they are so overwhelmed. They're just exhausted. They don't, they work like 80 hours a week. I don't know if they still do that. I've heard they've tried to like really rein that in, like how much they're working because it's not safe for the patients either if they're exhausted all the time. I've heard if you love arguing, you should. I mean, I love. Was it Will Flannery, Dr. Glockenflecken? He does a lot of the nephrology, cardiology beef, like skits, and they're hilarious. It's like the Wild West showdown. You hear the whistling in the background, a little tumbleweed rolling across as they stare at each other. Yeah, it depends on your specialty. Have I ever seen a clamshell thoracotomy? No. I've never seen that in person. I think that'd be awesome. I have seen a post-op open chest, though. That was wild, like, where I could actually see the heart. That was wild. I remember thinking, "Is this real? Like, does this really happen?" And the cardiac ICU nurse was like, "Yep." I was like, "That is wicked." I was like, "Man, they just leave it open?" Yeah, left it open. Yeah, I never got to see that in the trauma bay. I've been in the trauma bay a lot, and I never got to see that. I've seen lots of gnarly things, but I never got to see that. How do well, so I don't determine that. That's not my that's not in my scope of practice. My job is to basically advocate for my patient. If my patient is reporting so pain is subjective. I can't there's no way to objectively measure pain. So if a patient tells me they're in 10 out of 10 pain, that's what I chart. That's what I tell the physician. I go to the doctor and say, "Hey, patient in 5 or whatever room they're in, saying their pain's 10 out of 10, they're asking for something for pain," and that is it. Um, so yeah, I would have to, like, defer to them. Now, some hospitals, depending on where you live, there are regional agreements where you can actually have what they call it's like an emergency department. What was it? ED reports. It's basically if you get a patient who is checking into multiple ERs in a region, as soon as they check into one of them, there's a printout that gets faxed to that hospital they just checked in. And be like, "Hey, this patient has been to this hospital, this hospital. They've been to, you know, local hospitals 108 times in the last 6 months. And this is what their complaint was. This is what they've asked for." And so that is in one way that's, kind of letting you know like this person is shopping around. Um, are they shopping around for medications? Are they shopping around for somebody to diagnose what their issue is? So I don't know. Epic is good with that. Yeah. I mean, like the whole opioid epidemic is really been bad for people who deal with chronic pain, like who need legitimate pain relief because I think there's that stigma that if you come in asking for that and that's the only thing that works for your pain, I think there is that tendency to be like, "Oh, they're asking for opioids. Okay, we know what this means." And that's unfortunate because I think for every even if you're like 9 out of 10 are seeking, if we're not treating that one, that's unfortunate. But you also don't want to feed an addiction too, and that's a fine line, and that's one I don't envy the doctors because that's their call. I don't envy them to have to make those decisions. And I thought about how come we can't chart because we're using Epic at the clinical site. I think charting would be great. Being able to chart would be wonderful. However, this is their first clinical experience. I think charting would be too overwhelming. That is why it is a foundations class. So I'm actually okay with just focusing on the basics because if charting, oh my God, they're going to do so much charting in their career. I'm not really worried about that. And Epic, you don't really have to chart a lot in Epic. It's a lot of just check boxes, right? Like you check this, check this. It's charting by exclusion or inclusion, depending on how you look at it. So yeah, JME, thank you. Somebody came in early, was like, I don't understand why people play music. And I'm like, because we like it, and this is like the music that I identify with. Just for that, I'm gonna turn it up a little louder. Good morning, Mr. Clean. Welcome in. Who farted? I had horrible lupus pain and needed help, but the doctor and nurse both said I was drug seeking. I mean, that's not. I don't know. I don't agree with that. Yeah, Candlebox is good. See, people love the music, right? They connect with it. It's just that one grumbly person that didn't like it. Janice Shock, thanks for the follow. That reminds me, like, I had a doctor, whenever somebody was in, like, septic shock, he would go, "Septic shock." He was a weirdo. Great doctor, but he's kinda funny. Let's see here. Trauma surgeon is a type of subspecialty in surgery, usually working oh, yeah, there's, if you're interested in that, there's, Trauma Bay, like BAE. She's a trauma surgeon. I love her stuff. She's so funny and educational and snarky. So you should follow Trauma Bay. She talks a lot about trauma surgery. Uh, Jubs, my brain MRI report says possibility of demyelining process. As someone in mid-20s, do I panic? No, I think you just have it says possibility. You need to just talk with your neurologist after they review the report. Should I pursue nursing? Only if that's where your heart is. Like, you gotta be in it. Like, you don't choose nursing just because it's a job. You gotta I mean, you're gonna take care of some sick patients, you're gonna do some pretty nasty things, and you gotta be prepared for that. Like, you gotta have the right mentality to do that stuff. Jamie, thanks for the follow, I appreciate that. Candace, why did the ER try and make me wait with me screaming in a history of kidney stones? The sickest go first. I understand kidney stones is very painful, I've had them, but if they don't have room and there are no open beds and the people are sicker than you, then, I mean, that the sickest go first. I can't speak for them. I mean, if somebody's screaming in pain, like, we're typically gonna try and do something for it, but I don't know. I hear that a lot, but ERs are overwhelmed. Oops, meant to say oh, yeah, that's what I figured it was. But again, like, I could be wrong. There could be some term that I'm not familiar with. Yeah, but I don't worry until there's something to worry about. So I would just wait until you speak with your neurologist and figure out what's going on. Let's see, I've taken a finger off and crushed my foot, but I think I did a that's a lot. That's a lot going on. So this is I guess this has become like an analgesic being labeled as a seeker live. I'm getting a lot of those comments in here now. Yeah, don't be a nurse for the money. You'll be disappointed. I mean, there are a lot of jobs that actually pay pretty good, but for the amount of work that you do and stress on your body and your mental health, there's some arguments that could be made that it's not worth all that. So, oh, the other thing that I'm really focusing on with my students is save your back. Like, I see a lot of them leaning over the bed to like do blood pressures. I'm like, that bed costs like $50,000 and will go up. Push the button, save your back. You're young now, but you will not always be young. Save your back. And they're like, oh, okay. And they raise it up. I'm like, oh, that's a lot better. I'm like, see, it only took like 15 seconds. Save your back, because years of leaning over like that is going to strain your back. So, yeah, I'm teaching them early. Take care of yourself. Uh, Kian, I left the ER AMA, but the doctor wanted to keep me even though my tests were fine. They probably saw something. I mean, I don't know many doctors who want to keep a patient unless there's a reason to. Like, if anything, they're trying to get them out of there, and sometimes they want to discharge them even maybe they need to stay a little longer. Yes, you only have one back, and once they start messing with it, once they start operating on your back, it's never gonna be the same. It'll never be the same again. Ask anybody who's had a back surgery. Every once in a blue moon, you'll be somebody that say, "Oh, yes, I'm better now because it was so bad." But most of the time, I don't know why you wanted to keep. I don't know what your labs are. I don't know what the imaging results are. But if they wanted to keep you, there was something they were concerned about. But I don't know. I wasn't there. Why would an ER doc send me home when I'm going in and out of consciousness? I have POTS and heads. I don't know. I mean, POTS is a chronic thing, but I don't know why. I wasn't there. I don't know what the results were. I don't know what medications were given. I don't know your medical history, so I can't make that decision. I can't make that call. Todd and George, my husband was diagnosed with cirrhosis and now has fluid around his liver. Okay. So they're gonna do a paracentesis, like drain it? Are they gonna admit him to the hospital? Let's see. Ames says my boyfriend, who's a veteran, even says nurses get exposed to more PTSD than soldiers. Yeah, I mean, I think on a daily basis, probably. I work with a lot of veterans. Like, it depends on what their experience is. Like, I work with some combat vets who have like multiple tours of combat and have seen a lot of gnarly stuff. Like, I've seen a lot of gnarly stuff, but not under the austere conditions. I think for somebody who served without combat, sure. I think nurses definitely see a lot more, but, having worked with combat vets, and they don't really talk about a whole lot of it, but I do know that they've seen a lot of stuff. So, yeah, There are those that have seen way more than I'll ever see, and I don't envy them for that. Yes, use that bed, use the tools to your advantage. If he can't raise the bed, if they're sitting in a chair, then you sit in a chair next to him. You never raise the bed? Yes, raise the bed, save your back. Oh, this is the other thing I found interesting. Like last week, we did clinical when we had clinical last week, we had 1 bariatric patient. This time we had 3 bariatric patients, all in excess of 400 pounds. And that I think that was a good learning opportunity for the students to learn how to provide compassionate care for patients who are in that condition. And I think they also understood that that is not like last week wasn't just an anomaly, right? That is not just "Oh, we don't see that very often." No, no, no. We actually see that quite a bit. Do you send people to urgent care if it's busy? If the ER is busy, it depends. Where I work, we actually have an urgent care in the hospital. Um, so if they come to the ER and we are slammed and they have a sinus infection or I don't know, their ear feels stuffy, then yeah, we're not gonna make them wait. We're gonna send them if the quick care clinic is open, which is Monday through Friday business hours, then yeah, we'll triage them. I'll call over to quick care and be like, "Hey, I'm sending one to you, left ear's clogged up, wants to have it looked at." And like, "Cool, send them over." And they'll get over there, they'll take a look in their ear, and they'll say, "Yeah, it's clogged." "No, it's not." If it's clogged, they'll irrigate it. If not, they'll discharge them. Oh, that was weird. Ah, there we go. Did some weird stuff. I must have clicked something. Hey, thanks for the roses. Appreciate that. Aid 2, sorry. Not aid, aid 2, aid the second. Let's see here. Have you guys experienced miracle during surgery? I don't work in the OR, so I cannot testify to any miracles, and I don't believe in those. I am not of that persuasion. N No disrespect to those that are, that's just not where my personal beliefs are. I wonder, because I burnt my finger really bad last week and I was gonna go to urgent care. Yeah, for a burn, like, if it's just a burned finger, I mean, you can go to urgent care and unless it's infected, I'm not sure there's a whole lot they're gonna do, but if there's a blister, you know, I don't pop it, just let it go on its own. Just yeah, but I mean, like, I would just monitor it, make sure it doesn't get infected. Ames, have a great day. Thanks for stopping in. Oh, some comments were filtered to protect the community's experience. That's good. I like that. This says it's yours. Oh, I did. I guess I turned it on because we do talk about some kind of like nasty stuff. Yeah, because I do every now and then I get like younger folks in here, like teenagers that are asking about nursing, which I'm okay with. But sometimes we talk about pretty gnarly things that I don't necessarily think teenagers need to hear about. So that's why I restricted this live. I think it's defaulted to restricted to 18 and over. So, and that's probably good. That's safer for them. I'm gonna peek over here to see if anybody has come onto the site. No, no Substack viewers. I've had one viewer on Substack, but that's okay because Substack's gonna make some really cool clips that I can then share out later. Kind of like Riverside does with podcasting. Your ER sucks so bad. Oh, I'm sorry. I like our ER, and our veterans seem to like our emergency department, so that's good. Oscars Rios, wish me luck. Going to med search test and then psych after that. Psych test too, or just psych class? Well, good luck on your med search test. Have any interest in flight nursing? I I do have an interest in flight nursing. I did there's a program called Echo Heliops, Future Flight Crew, and I did that 6 years ago. It was during COVID. We started before COVID, and then we had to end we had to do it virtually for the rest of the year. But it's like a 12-month, well, 10-month, but it turned into like 12. A year long preparation program where you learn how to be a flight nurse or a flight paramedic. Um, we did a really extensive conference down in Chattanooga, Erlanger Life, and we learned how to do finger thoracostomies, surgical crikes, needle crikes, how to suture chest tubes. We learned how to run Impella pumps. We got extensive training in that. So we do a lot of extensive training. And then every month is like a new system. So like one month you focus on cardiology, pulmonology, neurology, trauma. You focus on all the gas laws. You have to know the gas laws in and out. So yes, I have been trained to be a flight nurse, and I would love to fly. My issue is that where I live, there is only one flight agency, and I would take a significant pay cut to go fly. I make I make good money as a nurse, but I would take a pretty big pay cut that I cannot afford to take. And that's unfortunate because I would love to fly. 2 tests, Oscar, good luck, man. That's a rough day. Adenosine is what we use to treat, like SVT, supraventricular tachycardia. As long as they are stable, then we will start with adenosine, 6 milligrams. If that doesn't work, we can go to 12 milligrams. If they're unstable, then we're going to shock them right away because we don't have time to wait because they're in danger of going into like a fatal arrhythmia. Yeah, I know. I Now the local program does have a flex position where you only have to work one 24-hour shift per month, and I could totally do that. The only problem is the orientation for that position is the same as a full-time position. It is a full-time orientation. So I could not work my regular job and I can't step away from that job to do that training. That is assuming they'd even hire me. Like I definitely have the qualifications, but it's a very competitive position. So I don't even know if they would hire me. Angel, I have undiagnosed blisters in my mouth. I'm having trouble swallowing in heart. I would You can try the urgent care, but if you're having trouble swallowing, I would probably go to the ER instead. Because I would imagine the urgent care is probably gonna be like, "You're having trouble swallowing? You should go to the ER instead." I mean, that's what I would do. Adenosine is so painful to receive. I've not heard that it's painful. I mean, everybody's experience is different. Generally what I get is I didn't like that. That felt awful. Like, it's your heart stops, and that's what it feels like. It's right before you pass out. You see these athletes who go into sudden cardiac arrest, commotio cordis, they get hit in the chest, and then that interrupts their heart rhythm and causes the heart to arrest. And then you'll see them walk, and then all of a sudden they literally just out. So when you have adenosine, we're basically doing the same thing, only it doesn't last as long. It doesn't last long enough for them to actually go out. It's just that pre-arrest feeling they get like, ooh, ooh, and that's because the heart's not pumping. It's not actually pumping blood, so they're not getting perfused, and so they look like they're about to go out, or they feel like they're about to go out, and then the heart restarts, and then, oh, okay, I can catch my breath again. Yeah, impending doom is like the common description. Like I felt like the end was near. Probable. Thanks for the follow. Appreciate that. Mickey, is it Mickey or Mikey? Oh wait, it's you actually say that. Oh, and I can't. Mishi. I see it, but I can't read the whole thing. It's truncated. Sorry about that. Probable. Thanks for the daily heart me. I appreciate that. Cardioversion can be painful, but I give a touch of etomidate before those. Okay, yeah. I mean, etomidate's one. Sometimes it's something else, but yeah, we try if we know we're going to cardiovert them, we do try to give them some type of sedation. Mishi, got it. Mishi, thank you for clarifying that. I always want to make sure I try and pronounce people's names correctly. Angel, thanks for the rose. Appreciate that. This has been a nice chill live. Like I really have enjoyed this live. For those that are new here, I'm just gonna for those that have been here for a while and have come to my live streams on a regular basis. My name's Gary. I'm an emergency room nurse. I've been a nurse for 10 years now. Obviously, that is not my first career. I'm 51 years old. I started my career in 1991 as a radio show DJ and host. Worked in television as a news anchor and reporter, then went into sports as a sports anchor and reporter, worked in newspaper, back to radio, had my own radio show for a while. Then I got into corporate communications, became an EMT and firefighter along the way. I've been an EMT since 2003. I still run today on a volunteer basis. And then my full time job is an ER nurse. I've worked level one trauma during the pandemic. So I've been through some shit. And as an EMT, I've seen a lot of things. Got 3 kids, married. Yeah. And there you go. Nice to see you. Thank you for coming in. I do this most mornings around 6:30, depending on what's going on with the kids and whether or not I'm on vacation. So I don't have a vacation coming up until July. Just went on one in December for Christmas, and we're going again in July. How many? Oh, Cypress in the house. What's going on, Cypress? Mishy, I hear you. I worked level one trauma for 18 years. Yeah. Did you work during COVID? Level one trauma during COVID was a wild ride. Yeah, Ellie, in 51 years, I've done a lot of things, and I got started pretty early. So I was 16 when I started in radio, and was very, very fortunate and grateful to have those opportunities. Yeah, wild to say the least. I feel like I've seen and done a lot. But every day I'm proved wrong that I've not seen it all. Like I learn something new every day. Like I learned yesterday, Amanda Donnell sent me this video of this woman who had it's like a defecation MRI. I had never heard of this. They inject like some type of blue gel into your colon, and then you go to an MRI, and then they will tell you like for 45 minutes, they just tell you to bear down and try to evacuate it. It- I did not know that was a thing until yesterday. So I learned something new. I looked it up. I was like, this can't be real. This isn't real. It's, in early April Fool. No, I looked it up. It's real. I had no idea. So, and it was like this woman who had it done, right? And she's like super fit. And I don't know, I didn't hear the backstory, but she was explaining the process. And I was like, this is nuts. I did not know this was a thing. Yes. And I like if I didn't read it, if I didn't look it up on a reputable site, I would not have believed it. It is no. And of course, this poor woman, she was like, and then like I think she actually prolapsed during it. And, like, the gel was, like, stuck up inside of her. She couldn't evacuate it. She evacuated her rectum instead. It's like, oh. And she was, like, really I mean, this is afterwards, so, like, now she can kinda laugh about it, but yeah. I don't know if I shared that. I've got it. I'll share it out on my I'll repost it. Yeah, but she had a really good attitude. So, but I could see she had, she had, like, fluids running her. I think she was at home, so she must be dealing with something chronic. But she looks jacked, like, she looks like she was a CrossFit athlete or something. So, yeah, I think I've seen and done a lot. I'll never ever say I've seen and done it all. Never, because every day I'm proved wrong. What do you know about rad tech, like radiology technologists? I know they're awesome. I love the ones we work with, especially when they come and get my patient and I don't have to take them to radiology. That always makes me happy. No, they're great. I know them all by name and they're good people. Sometimes I wish I'd have chosen that. Their pay is pretty close to what I make and they don't have to wipe butts. But I like critical care. I like doing lots of fun stuff and they don't get to do the same fun stuff we do. Paramedic to RN John Smith, my man, what's going on, dude? Yes, when they come and get your patient, that just makes my day because that means I can do other stuff. Have I ever run into anyone with obvious parasite infection? No. No, not a parasite infection. Yes, defecation MRI diagnoses pelvic floor dysfunction. See? I mean, like, how many of you knew about a defecation MRI until this live stream? You are welcome. I learned it, and I'm gonna pass it on to you. John, did you know about this? Defecation MRI, have you ever heard of this? Tia, how can you wean off laxatives safely? That's a good conversation for you and your GI doctor or your whoever prescribed it. Like, that's a good one to have with them because I'm sure it's gonna involve increasing your fiber and, making sure you stay hydrated. But I would before you do that, before you risk, like, constipation or something like that, I would talk to your doctor first. Paramedic Arn John Smith just finished 12-hour shift change, so doing great now. John, I ordered a tripod, man. I did it. It's on the way. We're gonna put up we're gonna put up the board, and I'm gonna write really messy on there. We're gonna talk about topics. I'm blatantly stealing from John, but he actually told me to do it. He said, "Just do it. Just get it and do it." So I'm gonna do it, man. I didn't until I saw our video. Literally had I know, right? I thought it was like it's not April 1st. Like this, if this was April 1st, I would not have believed this, and I had to look it up. What's the calm medication before surgery? It depends. They can do Versed, they can do I don't know, the best one I've ever gotten is propofol. Best sleep I've ever had. Knocks you right out. I know, right? So I've got a couple of things that I drew out like years ago when I was in nursing school to help me remember things. And since I'm doing clinicals, I think I'm going to kind of focus on like the little things like that. I'm not going to do the things that you do. Because you've got that down. I will just send people to your page and your lives for that. So I've got some other stuff I want to put up here. Mostly a lot of things that have come up during my clinical time with my students. And I'm like, you know what? This would be good for a lot of people to know. So I'm going to write those out and we'll put that up on the board. So if you don't follow Paramedic Aaron John Smith and you like to learn things, you should go follow him. He has a lot of educational components and he does a lot of lives where he actually does Q&As and he covers a lot of very basic nursing and paramedic stuff. If you're in paramedic school, nursing school, his lives will help you out a lot. Rule of nines, he does a great thing on rule of nines. I benefit from that. It's a good refresher if you don't deal with it on a regular basis. Kian tries to fight the anesthesia. I think we all do, right? We're all like, I'm going to be the one. I'm going to be the one that can count to 20 on propofol. You're not. You're not that guy. None of us are. Propofol wins every time. Although I will be interested to see the next time I have to have, because I have to have another colonoscopy in like 5 years, right? So I'm down like almost 35 pounds. And propofol is a fat soluble medication. So the more adipose tissue you have, the longer it's going to take for that to wear off, right? Because it's kind of like loves to go to that tissue and it takes longer to come out of it. So I've lost a significant amount of weight. So I'll be curious to see how quickly I can come out of that. It wasn't that long before, but again, I think with a lot like 35 less pounds of fat, I think it'll be interesting to see how quickly I can come out of that. But propofol is the best sleep I've ever had. Literally don't remember a thing. Nothing. No dreams, just lights out. And then it looks like you blinked your eye and you're in recovery. Mishi lost 150 pounds on your own? That's amazing. Wait, like legit, or did you dump somebody? Because I've seen those posts too, where it's like easiest 150 pounds I ever lost, and it was like they broke up with their boyfriend. But if you lost 150 pounds on a weight loss journey, as long as it was healthy, the healthy way, that's wonderful. That's amazing. That's like a whole person. That's incredible. So I've got a 25-pound weighted vest that I use, and I've been doing a lot more walking, with that weighted vest. Like, when my son has soccer practice, they have it on like a high school track field, so I'll just put it on, I'll just walk around the track, and when I'm home, I'll just walk around the neighborhood. We live in the mountains, so I have a lot of hills. It's a great workout, but man, I put that on and I realized this vest weighs 25 pounds. I have lost this amount of weight plus 10 more pounds. And that is just when you feel how heavy that is, you're like, that's a lot of weight. Now 65 pounds, Kodalo from Canada down 65. Congratulations. Kept it off for over a decade. That's amazing. That's incredible. Let's see. No, I'm not based in Australia. No, I do get a lot of folks from Australia that come into my lives, though. I don't know what the algorithm does for that, but I every live stream I do, I get usually 1 or 2 folks from Australia. I mean, I would love to live in Australia. Well, I don't know if I'd love to live there. It gets pretty hot. I'm not a big hot weather person, but I do think Australia's a beautiful country, and I've never been. Nor. He doesn't say nor. Now, it's funny because my kids will say that because they watch a lot of Bluey and they listen to a lot of, I guess, Australian stuff. So I hear them say nor. And one of my favorite Peloton instructors is Australian. So I hear her say it a lot too. Should I get my left knee replaced first or my right foot's bones fused? I'm I'm an ER nurse, man. Like, I don't or Jesse, I don't know. That's a conversation you had with the orthopedic surgeon because typically they're gonna be the ones that are gonna make that decision. I don't know. If they're giving you a choice, that's a personal preference. I don't know which one's gonna have the best improve my quality of life first. I know a nurse and she says the paramedic forbidden to use large bore catheter on a tension pneumo. Interesting. Oh, let me know if my audio changed. I got one of those weird notifications. If it changes, let me know and I'll fix it real quick. I'm confused. They both cause me pretty bad pain. I don't know. That I'm not an orthopedic doctor. I'm not a surgeon. I cannot answer that question. I wish I could. Sounds great. Thanks, Holly. Appreciate you. Azure Nights. Yes, you may ask a question as long as I've got moderators in here. We can shut it down though. Jesse, I'm confused. Oh, gotcha. Yeah, I wish I could help. I mean, for me, if it was me and I had to make that decision, my decision making process would be which one is gonna. I might go with the one that has the shorter recovery time first, so I can get better and get ready for the next one. Does that make sense? So, like, if the foot is a faster recovery time, I might do that one. That way, I can get back to a position where they can do the knee next. That would be my thought process. But again, I'd have to talk to my orthopedic doctor and be like, what do you recommend?" I know if you get a knee replaced, like they get you up and walking, I mean, like a couple hours after your surgery. Like it's pretty quick. Like they don't it's not like oh, you get to lay in bed for 3 days. No. They are up moving you. How do I stop tooting? Well, it's probably dietary related. If you're taking in a lot of fiber, sometimes that's just there are over the counter medications you can take, like Gas-X, that can help with that. I mean, but if you're having any other symptoms, any abdominal pain or anything, you should talk to your primary care doctor, your GP, general practitioner, PCP, primary care provider, whatever. Yeah, the foot surgery, I'll be off my foot for 3 months. Yeah, yeah, surgery of the feet can be pretty that's a pretty long recovery time, so I don't know. It depends on what they're doing. If they're fusing bones, I don't know. I'm not an orthopedic. Do I enjoy working in the ER? Yes. Does it have its bad days? Sure. Every job does. As far as nursing goes, I started my career in the ICU. I love critical care. It got a little boring, especially when you got the same patient and we weren't really doing much. Like they were just kind of like maintaining. That kind of was boring. I like the ER because it's always changing. You never know what's going to come through that door. You never know when someone's going to go sideways, crump, and I like that uncertainty. I like being able to think on my feet, be able to jump into action. I like using my critical care skills. So I like the ER best. Man, there's another question. How often do seekers come in? I don't know. I don't. We don't actually have like a label for seekers. Like, there's nothing that goes on their chart that says they're a seeker. So I don't know what the answer to that question is. We get patients that come in that are specifically asking for certain medications, and I'm sure that can be interpreted as they're seeking. But no, I'm just taking beans. My doctor recommended this diet to me. Well, yeah, if it's legumes like beans, that's fiber, and that's gonna increase, your flatus. I love that word, flatus. Why does my knee crack when I bend as a 16-year-old? That's a good question. If you play sports, if you have any injuries, is if there's pain, then you should get an orthopedic doc. You stay, talk to your parents and have them take you to an orthopedic doctor to see what's going on. How long do you have to study become in order to become one? Become one what? What was your previous question? A nurse? I don't see another question from you. If it's a nurse, it depends. There's LPNs, there's associate degree nurses, there are bachelor's degree nurses. So 2 to 4 years generally, depending on where you go. Oh, microbiology? No, I can't do that. Microbiology was a prereq. Yes. Do we use it every day? No, not consciously, right? Like there's a very basic understanding of like microbiology. It's kind of like math, right? Like you don't think you use math on a daily basis, but you really do. Like when you are walking and you are calculating in your brain without even thinking how to step over things or how to get somewhere the fastest, like you already know the fastest, the quickest way to get somewhere is a straight line, right? That's geometry. So you're already using that to some degree, just not thinking about it. Microbiology is the same kind of way. Like when you're thinking about antibiotics, you understand that there's, you know, breaking down like the cell wall and you understand like there's different ways to lyse a cell or something like that. So you're not thinking about it consciously, but you've learned about it, so you have a basic understanding. But no, not like on a detailed level. You're not going to be using microbiology on a daily basis. Not as a bedside nurse, you're not. Now, if you work somewhere else, like if you work in a lab or you're doing research, yes, then you will probably use that on a daily basis. Do I have any interesting stories while working as an ER nurse? Sure. I got lots of interesting stories. Can I share them? Probably not. Oh, who remembers this song? See, people love the music in the background. It reminds you of certain parts of your life. Brown Eyed Girl, I've gone from an average 8 liters. What is that? Thanks for the weekly 8L monthly. I don't know what that is. Any advice to pre-med student to remember information from studying? If you're pre-med, I don't know. Like it depends. Everybody learns differently. Some people it's memorization. Some people like to develop mnemonics, create little songs in your head. I don't know. I think it's different for everybody. I would diagram things. Like I drew things out, especially with anatomy and physiology. Like when I was doing like renal function, I have like this very detailed kidney diagram that I did with blood flow and the tubules and all that kind of stuff. And that worked for me because spending that time really ingrained, like helped solidify the knowledge that I was taking in. Do you guys actually write No, I don't. I don't do that. That's not As a nurse, that's not my job to do that. If the physician puts that in their notes, that's on them, but that is beyond my scope. I cannot diagnose. So, no. How often is staphylococcus an issue in the ER? I don't know. I feel like it's pretty common. It's funny. I had a patient yesterday, not me, as a clinical instructor, our nursing students had a patient and I was like, "Oh, they're on precautions. What are they on precautions for?" Because we already had one C. diff, and I only knew of one C. diff patient. This was not that. Paramedic Anthony is in the house, and it's April Fool's. Don't believe anything he says. He's a jokester. He's not new here. But good to see you, man. How are things down in Texas? Um, so anyway, this patient ended up having MRSA, and I kinda looked at it, and I, was like, yeah, I don't care." I said, "You know what, though? Because you guys are here, we're gonna do this by the book, so I'm gonna gown up, but ER nurses are not gowning up to go into a MRSA room, generally speaking, but we were on the floor, I'm setting a good example, I want them to be safe, so I begrudgingly gowned up and went into the room and did all the things by the book because I gotta, set a good example, but in the real world, no. There are even ICU nurses that are, like, not gowning up for a MRSA infection that is not even, like, active, just a history of, right? No open wounds or anything like that. Thanks for the daily heart me, Anthony. Appreciate that. Jesse, I hate doctors and nurses who treat chronic pain people like drugs. I mean, I hate's a strong word. I don't do that intentionally, and it's not my job. Like, I just pain's subjective. That you tell me you're 10 out of 10, I'm gonna chart 10 out of 10. I'm gonna tell the doctor patient's 10 out of 10 pain and is requesting analgesics. And that's the extent of it. And I'll continue to advocate for the patient, but it's beyond the scope of my practice to prescribe anything. I cannot do that. I can only advocate for my patients. Hello, Mickey. You're so fine. You're so fine. You blow my mind. Hello, Mickey. Thanks for the follow. Appreciate that. Paramedic Anthony just got off shift. Cool. Stop with the yellow hearts. You're not new here. Null Arc 11. Hi, Gary. I did wound care on necrotizing fasciitis foot yesterday with betadine and very cool. And inodine. I don't know what that is. I know betadine, but I've not seen inodine. We had a patient on the unit yesterday who had a guillotine amputation of a limb because it had necrotizing fasciitis. That was, I guess they could not treat it. So the limb had to come off. And I got to tell you, those are the cleanest staples I have ever seen. It looked like, I'm not a surgeon. I've not worked in the OR, but I've seen lots of post-op like sutures and staples. And that was the cleanest I've ever seen. And it was impressive. Brett and B. Nolan, thanks for the follow. Appreciate that. UC Mystic, what's really annoying is having to gown up to go in an IMM to get an IMM signed. What's an IMM? I'm sure everybody has like their own version. Like we have what they call opt-outs. So if they're admitted to the hospital and they want to be listed on a registry so their family can call and check on them, they have to get an opt-out signed. But we don't let registration go in there and do that. If they're on contact precautions or any type of precautions, we'll take it in and do it. Minimize the risk. Heard there was a MSSA pandemic called USA 300 for about 2 decades. I'm not familiar with that. I'll have to look into that. Paramedic Anthony had a nurse ask why I didn't gown up for West Nile. What? Why didn't you? Did you know they had it? I don't know. I don't know what precautions are for West Nile. That's that mosquito one, right? Yeah, I mean, like, it's not contagious. It's just a mosquito bite, right? As long as you're not like, it'd just be standard precautions, just like you would do it for any other bloodborne, right? I don't know. I've not had anybody with West Nile. I feel like that was what? How long ago was that? 10 years ago? Oh, we had a nurse write us up from the floor because the patient, the COVID was negative. Like I guess the rapid COVID, the PCR was negative, but they did the antibodies and the patient had positive antibodies and they wrote us up for sending a COVID positive patient. Literally had to call the nurse and be like, that's not how that works. They do not have an active COVID infection. Their COVID was negative. Their SARS COVID was positive, but that is because they've had it in the past. They have antibodies for it. That's what tested positive. They do not have an active infection. You wrote us up for nonsense. And she was adamant. She's like, they're COVID positive. No, they're not. COVID's negative. They have antibodies. There's a big difference. So yes, some nurses are just looking for a fight. Good morning, Nurse Jelly Beans. Welcome in. Look, we got somebody from New Zealand in here. Wavy baby. We get a lot of Australian folks in here. And for some reason, somebody thought I was from Australia. I just got a really terrible accent. Not from, but maybe based on Australia. I would go there and work. I don't know what the licensure would be like. But Wavy Baby is a nursing school in New Zealand. I'd be curious to see what nursing school is like over there. Like, what part are you in? Are you very early in nursing, or are you like towards the end of your nursing school career? And what kind of nursing do you want to do? Yeah, it's bloodborne, right? That's what I was thinking. You would just treat it like anything else, just gloves. It's like when somebody tells me, "Hey, your patient in 6 is HIV positive." I'm like, "Thanks. I assume they all are. I wear gloves." I mean, I guess it's good, but like, Even if they're not diagnosed with it, you don't know what people have. Like, you should be using gloves on every patient when you draw blood. I don't understand people that pop the tip off of a glove to feel a vein. I don't get that at all. That's right. Thanks for the info, but I just assume everybody's got something I don't want, and so I'm gonna wear gloves. I know, that's how I feel. I do. I literally just look and I'm like, "Thanks. Okay." It literally doesn't change anything I'm gonna do. Still gonna wear gloves. Yes. So, I mean, in a sense, yes, they have. I don't know. There's not one medication that they can give to cure it, but they have gotten to the point where they've had patients who are HIV positive that no longer test positive and are what they define as being cured of it. So, yes, but there isn't like a single medication. It's a series of medications I think they have to give in order to eradicate it. And I think it takes time. It's not something that can be done overnight. Yeah, undetectable. That's the word I was looking for. It's to the point where it's undetectable. Anthony just likes yellow hearts. All right, man. I'm gonna change it. I bet your favorite color will change if I change that. Just because that's who you are. That's right. Nikki, thanks for the follow. We got quite a few nurses from north of the border, Canadian nurses that follow me and come into the live. So they're pushing out to Australia, New Zealand, and Canada. All right, all places I want to go. I've been to Canada. I want to go to New Zealand and Australia. How do the nursing ranks work in the US? What do you mean by ranks? So in the US, like we all go to a very similar nursing school system, right? And then depending, it doesn't matter where you go, we all have to take the same test. So whether you get a bachelor's degree, which is a traditional 4-year university, or you go to like a community college and get an associate degree as an RN, we still have to take the same test. So it's called the NCLEX. Once you take the NCLEX, you um, basically can be licensed. You apply for licensure in whatever state you're in. Most states in the United States are now part of what they call a compact license, which means if you have a license in one state, you can move to another state and practice without having to transfer your license. Not all states are part of this, but more and more we're getting to the point where it's going to be kind of a nationwide thing. Then from there, you can go into whatever type of nursing you want to go into. If you want to do ICU, ER, med surg, hospice, it doesn't matter. There are different specialties that you can go into, and each specialty has additional education. So emergency room has certified emergency nurse. It's like you study for a test, then you take the test, you pass the test, you are now board certified as an emergency nurse. They're really hard tests, and it takes, it's not something you can just study for a few weeks. You need to really devote some time to it. ICU is critical care. There's a CCRN for ICU nurses. Flight nurses have their own. So yeah, but generally speaking, once you graduate and pass your NCLEX, you can go into whatever form of nursing you want. Which smell before lunch? It doesn't matter. I'm an ER nurse. Like, doesn't bother me. Smell it all. Sit there and eat anyway. How much practical training do you get in school? Not as much as you should. That's probably one of the biggest complaints of nursing students is they don't feel like their skills are developed enough. You learn most of that on the job. Anya's mom, thanks for the follow. Appreciate that. Juggernaut, what state? I am in Virginia. What can your ER techs do in your ER? They can start lines. They can do EKGs. They can do bladder scans. They can't start or stop meds. They can transport critical meds. I think there's only if they're on there's certain drips they can't. So heparin drips, cardizem drips, any like critical drips they can, but like they can take patients that are on antibiotics, fluids, but if they're on a critical drip, then the nurse has to go with them. VA is a good state. Yeah. I'm not from here. I just live here. It's nice. It's mountainous. I like mountains. I don't like flat. Gary, least favorite smell is TPN because then he's in the ICU. I started my career in the ICU. It's not terrible. But yeah, I'm not a fan. Did you notice the water change in Virginia? No. It depends on which part of Virginia you're in. Are you talking about Virginia or VA? Nurse Jellybean's got the level up sparks. Thank you. I appreciate that. How long have I been in Virginia? Cumulative? Like I moved away for a while, came back. So I guess this time I've been here for like 20 years. My ER won't allow me to place IVs, but can do straight sticks. That's weird. Like it's not that. I mean, if you can find a vein to stick it, you can find a vein to put an IV in, as long as it's straight. That's weird. So what is the minimum requirement? You have to be a nurse to put IVs in, or an EMT? I don't know. That seems strange. I mean, every hospital I've worked at, techs can place IVs. In fact, they're really good at it. Should I go to the hospital because I'm yes. If you're having chest pain, absolutely. You need to go to the hospital, like, as soon as you can. If you can't drive, have somebody take you. Oh, yeah, I don't know, and that's weird. I mean, saline technically is a medication, but you don't we don't have to have an order for that. So I don't know. That's weird. Hmm. Yeah, every hospital I've worked at, techs can do lines. Anya's mom. My 11-year-old B cell, all severe tremors, won't stop with meds. Doctors ignoring what do we do? Find a new doctor. Get a second opinion. That's as a parent, that's what I would do. What's the difference between CRN and an RN in the United States? I don't know what a CRN is. I don't know what a CRN is. Yeah. Oh, CNA. Gotcha. Oh, CNA. CNA is a certified nursing assistant. So they they can do vital signs. They take care of like basic patient care, like ADLs or activities of daily living. Bed baths, get them changed, ambulate, check vital signs. They can't administer medications. They can't start IVs. They can't do procedures. So I'm sure that I think bladder scans, they can probably do a bladder scan. I don't know. It depends on your facility. Every facility might be different, as we've seen with techs, right? Like the techs that work at our hospital, they can do a lot. But apparently in other hospitals, techs can't start IVs. They can draw labs phlebotomy wise, but yeah, CNAs are hard. They work hard and they're underpaid. They do a lot of the really dirty work. No, Stone Temple Pilots. I love them. Saw them in concert in 1993. Should we be concerned over the tremors treatment going well? I don't know. Like, there's so much information I don't have. Have you seen or heard of the flow patch? No, I've not. What is this flow patch? Educate me. I love learning new stuff. Lynn says it sounds similar to an enrolled nurse in Australia. So my nursing students that I have in my clinical group, they are like right now CNA level. They are proficient in doing bedside care, all the things most of the things a CNA, typical CNA would be allowed to do in the hospital. They can do those things. They've been getting better at that. But we are now starting to advance to medication administration, doing more thorough assessments. CNAs don't do head to toe assessments. So they're working on developing those skills. Pigs are not allowed to remove IVs for discharge, say in my hospital, which I thought was weird. Techs aren't allowed to remove IVs. That is weird. So my students are learning how to remove IVs, and they think it's the coolest thing ever. Like they're all excited to do one to remove an IV. We talked about this earlier in the live, and I thought it was kind of cool that they're excited about something that most of us feel is such a mundane task. But if you've never done it, it's a big deal to be able to do something like that. Do you think an ICU nurse can have a good transition to the ED? Yeah, that's what I did. I started my career in the ICU and then moved to the ER. It's a culture shock for sure. But yeah, you've got the critical care skills down. You gotta refocus your efforts and be ready for anything. In the ICU, it's more controlled chaos. Like typically your patients aren't going to just suddenly crump on you. Like there are signs. In the ICU, things are very meticulous, and you'll start to see signs of going downhill early. And so you start preparing for that. In the ER, things can go sideways in the blink of an eye. Literally the blink of an eye, everything seems okay, and then it's not. The world is on fire, and, you know, you've gotta jump into action and be ready to roll with it. What state am I originally from? I'm a nomad. I'm a military brat. I grew up in I mean, I was born in the States, but I didn't live there very long. I spent, like, many years in West Germany before we moved back to the States, so I grew up on military bases. Let's see. Had admission, my mom had a lactic of 3. That's, 2 is normal. 2.2 is normal, so 3 is not terribly elevated. 1 week later, she started declining, lactic of 16. That's way worse. That's really, really bad. And then, she died hours later from complications of sepsis. I don't know. I mean, I only know the lab value that you told me, so I don't know what happened in that week. I don't know what happened, so I can't answer that question. A lactic of 3, if other if there are other signs there, so we can look at lab values, but we can also, like, was her heart rate elevated? Was her temperature elevated? So that can all point to signs of, like, what we call systemic inflammatory response, SIRS, and then that can progress into septic shock, which is apparently what happened here. But typically, there are gonna be signs along the way, but I only know the 2 lab values that you told me, so I couldn't do that. I couldn't answer that question. It's a big deal, and I'm really glad you're excited for. Oh, yeah. I mean, like, it was refreshing. It reminded me what it was like to be excited about the little things that I think are little now, but at the time we're like, "Ooh, like, I'm taking out an IV, like, this is kinda stressful." So yes, it is kinda cool. Now, if they're nervous about taking one out, imagine how nervous they're gonna be to start one. Oh, yeah, lactic is 16. Yeah, at that point, I would say I wouldn't even be mad at you for some bicarb. Have I ever seen the show ER? Yes, I it's been many, many years, like 30 years since I watched it. I did go back and watch episode 1 a few weeks ago. I live streamed that while I was watching it, just giving my reaction. You know, it's for the time, I thought it was pretty realistic. It was very dark and dingy, which is very representative of what you will find in older ERs, like inner city older ERs. So I thought that aspect of it was really very realistic. But I've forgotten how much happened in the very first episode, right? Like, oh, the nurse, was it Carol Hathaway? Was that her name? Like, OD'd in episode 1? I totally forgot about that. You have been dubbed the king of bicarb. You need to run that through ChatGPT and create a caricature of you as the king of bicarb, like with a crown and then holding an amp. Linz, I was so nervous to learn how to do manual blood pressures, but now I feel excited to learn more. Oh, that's cool. Yeah, so we actually focused on learning how to do manual blood pressure. I mean, they know how to, but doing it on real patients is sometimes different because doing it on your classmates, they're compliant. They're gonna move their arm, they're gonna hold still, but doing it on a patient that's hospitalized and may not be responding normally can be a challenge. Plus, with all the other noise that's going on in the hospital, it can be a challenge. And the thing I told him is like, "Look, if you don't get something, like if you're listening and you don't hear anything, just say you don't hear anything. Don't make any numbers up. Just say, "Hey, I could not find a good blood pressure. Couldn't hear it." The other thing is I altered their position. They all like to put the stethoscope right in the like AC, right? I move mine more medially because that's where the artery is. Like artery kind of crosses over as it prepares to go into like the brachial, the underside of the arm. So I always put mine kind of more medially, and I feel like I hear it better there. Nurse Jellybeans, have a wonderful day. Thanks for stopping by. And I think once we adjusted that position, I think a couple of them were like, "Oh, I hear that a lot better now." Eloise, thanks for the follow. I appreciate that. Cuz 789, I love that. ICU to PCU, took her off BiPAP. She declined within 24 hours. BMP, oh gosh, BMP 25,000. So like all of her labs are, yeah, multi-system organ failure. Mods. That's what we call mods. Mm. Well, thanks for the follow. I appreciate that. I'm so sorry to hear about your mom. That is, yeah, septic shock is pretty bad. I mean, there's a lot of information that I don't have. I couldn't make an intelligent decision on that or judgment on that. Brown Eyed Girl, thank you for the follow. Appreciate that. Love to finish my work and listen to your live. Well, thank you. I appreciate that. I really enjoy doing these. It's it's therapeutic. I love to teach. I love to learn. Like I've learned a lot of stuff when people come in here is like, have you ever heard of this? And I'm like, I've not heard of that. And then I can look it up. And then it's sometimes something I can share with my students. And it's a constant reminder for my students that it doesn't matter how long you've been a nurse, you will always learn something new. And it's okay. I trust a nurse who says, I don't know that answer. I'm going to go look it up. Or I don't know. Let's look it up. Than the nurse who has an answer for everything. If the nurse has an answer for every single question, I'm suspect. And that goes back to my first bit of advice for all my students is trust but verify. Trust but verify. Do you have an idea of what could cause someone to have cold urticaria? Urticaria. So like itching all of a sudden? No. I mean, it could be any number of things. And I'm not a doctor. So I don't know. And even anecdotally, I don't know. I've not seen any patients that have something like that where I could be like, "Oh, this patient had this, had the same symptoms, and this is what they were diagnosed with." I've never heard of that before. Never seen that as a nurse. Dimples RN became the number 61 in the fan club. That's awesome. Welcome in. Brian Vaughn, thanks for the squirrels. Like, how did you know, right? I'm an ER nurse. Squirrel. Get easily distracted. That's our code for easily distracted. Squirrel. Let's see. Paramedic Anthony, antihistamine release, so it's fighting something. There you go. Paramedic Anthony's way smarter than I am. I mean, he has a badge. Like, he actually has a badge. That's how I know he's smarter than me. I don't get a badge. What's your absolute favorite department of working? Emergency department. Love it. Can't imagine working anywhere else. The only other place I think I could work is PACU. I could do PACU. I did PACU call very sparingly, but it was a good experience. You are, man. I think you're really smart. Like medics that actually work in busy systems, I when it comes to critical care, yeah, I would I would say they're smarter than me. I am but a humble basic and an ER nurse. Oh, we got an OR nurse in here. Dimples RN is an OR nurse. Welcome in. Thoughts on trauma ICU? I've never worked trauma ICU. I mean, I've worked trauma ER. I send you a lot of I've sent you a lot of difficult cases. I mean, usually I send them to OR first, stabilize them, and then send them to the OR, and then they come up to you. Tips for ED techs, tips to help be solid when it hits the fan. Try to remain calm, and then communication is key. So when things go sideways, it's important to have somebody who's kind of directing traffic. And if you see something that needs to be done that's not being done, just say, look at whoever is running it and be like, hey, I'm going to get you a line. I'm going to start an IV or I'm going to do an EKG. I'm going to get them on the monitor. Just communicate clearly. If you see something that needs to be done that is not, volunteer or just say, I'm going to get the IV or I'm going to do this or I'm going to try for an IV on the left. Amy Adams, 30 years in the ER, did some PACU. Yeah, I thought PACU was kind of neat. I didn't do a lot of it to make a really good judgment on it, but I would do it again. The Liz Effect, thanks for the follow. Appreciate you. This is Andrea, nursing school. Any tips to help understand fluid and electrolytes? Nursing student here. Um, so generally speaking, we used to pump people full of fluids, but if you're going to resuscitate somebody, if they're losing blood, they need blood, right? Fluids are not going to help. That's just hemodilute everything. It's going to throw all your lab values off. In terms of electrolytes, I mean, that's a big discussion. So, calcium, potassium, vital for cardiac function. You got to have that. If you have too much potassium, there's different ways to get potassium. So when we say there's too much potassium, what we mean is there's too much potassium in the extracellular space, not in the cells, right? So when we measure potassium, we're looking at like what is outside the cell. And there's a range for what we want outside the cell. When it gets out of range, we need to do something to get it back in the cell or out of the cells. So if it's hyperkalemic, like there's too much potassium, we got to get that out of that extracellular space and put it into the cells. There's different ways to do that. Albuterol is one way. Albuterol is going to facilitate transport of potassium back into the cells. You can also do the most common one is probably insulin. Insulin is going to facilitate transport of potassium back into the cells. But you got to be careful with that. If you're going to do insulin for hyperkalemia, then you also need to add dextrose in there as well, because we are going to crash their blood sugar by using that insulin, right? So you got to make sure you're giving them a steady supply of glucose as well. So, but typically, hospitals I've worked at, if you're doing insulin for hyperkalemia, you like it's going to require you to add dextrose into that order set as a protective measure. Sodium, if you're thinking like hyponatremia, so low sodium, replacement for sodium is very deliberate and slow. You cannot replace sodium too fast. You can cause a lot of problems with that. When we talk, someone's talking about calcium, the Lizafet, calcium chloride. So there's two types of calcium. There's calcium chloride and calcium gluconate. Now we can go back and forth. There's going to be arguments on to, like how you can give these. Calcium gluconate you can give through a peripheral IV. Calcium chloride ideally should be given through a central line. It is a vesicant and it can cause a lot of bad things if it infiltrates, like tissue necrosis. So we prefer not to do that through a peripheral line, but in a code situation, if that's the only access you have and they are like a tachyarrhythmia, their potassium's like 7.5 or 8, we need to get calcium on board and quick. Calcium chloride has 3 times the amount of calcium as calcium gluconate. So you'd have to give like 3 bags of calcium gluconate to equal 1 bag in the standard concentrations, then 1 calcium chloride. So ideally central line, but in a code situation or like it's a peri-arrest and we don't have any other choice, calcium chloride through a peripheral IV, depending on your hospital's policy, if they allow that, but if their policy is strict and says you must have a central line, then obviously hospital policy is what we always default to. But I have seen it given through a peripheral line in code situations. So yes. Amiodarone is another one of those. Ideally you should have that on a micron filter, but in a code situation, amiodarone. Yeah, amiodarone. In a code situation, though, you don't have to do that. But if you're given a steady drip of that, then you really need to have it on a micron filter. Let's see. Ben McGovern's a therapist. What kind of therapist? Like physical therapist, mental health? What is the sectioning process? What happens upon arrival? I don't know what sectioning is. We use calcium chloride and bicarb and crush injuries. I thought we weren't doing that anymore. I thought our protocols have changed. Like we're not doing bicarb for crush injuries anymore. We took that out of our protocols. I don't think the evidence is there to support that. I'm pretty sure. I'll have to double check, but I feel like that was a big push with our most recent protocol update. I'm going to take a look. Bicarb for crush injuries. Again, I feel like I'll have to double check, but I feel like we took that out of our protocol because I don't know if it was indicated. Don't hold me to that, but I'll take a look. Do ER people like shows like The Pit? Some do. I do, but I have a production background, so I like to look at it from a production standpoint. But some people don't because it's too close to home. It is very realistic, so it reminds them of their jobs, and they get enough of that at their job. They don't want to watch it on a show. So I understand that. Me, I look at it from a production standpoint because I have a background in that. So I like to look for continuity errors. I like to look for things that could have been like done better. When a client is not safe, it's my job to assess and send them to an ER for evaluation. What do y'all do? It depends on like we're going to give them a mental health evaluation. So my ER has a ER psychologist or psychiatrist. who will come talk to that patient and evaluate them for possible admission, or is it something that we can manage outpatient? Can we do a medication bridge in the short term to get them through until they can follow outpatient? So basically, if you send us a patient who's in a mental health crisis, our psychiatrist will evaluate them, or mental health residents, or whatever, whoever is on call. During business hours, we have somebody in house. And then afterwards, it's usually the resident on call who will come see them. Usually they're in the hospital somewhere. Did I see your message from earlier? There, no, I did not. There's a lot of messages. See, I think, oh, you think it means triage? Oh, yeah, I think I got that. Thank you. Yes. And it's your YOU apostrophe RE. You are bald. Thanks for that. Nothing loses me faster than misspelling that word. Also, can I follow you back? Yeah, I go back and I vet everybody I follow. So I will go back and look at the folks who followed, and I will take a look. Let's see here. Oh, I want to take a look. Oh, it's been 2 hours. Been 2 hours? It has been 2 hours. Oh, yeah. We'll go for like 4 more minutes, and I gotta get off of here. I do run rescue today, so. Elizabeth, thanks for the daily heart me. I appreciate that. Also for the roses. Thank you so much. Appreciate that. Yesterday I sent someone after an SI attempt. So what would have happened then? The most likely that's an admission. Because if they tried to leave, they would probably, if they have an active attempt, they would probably have been TDO'd, a temporary detaining order, and then they would have a 72-hour hold on them. So if they've had like a admitted or confirmed attempt, yeah, that's a immediate TDO. There's 72 hours. They're guaranteed to stay at the hospital or the psychiatric facility. So yeah, Liz Effect, thanks for the Go Populars. Appreciate you. So yeah, this is a long live. This is one of the longest ones I think I've ever done, but it was great. Lots of good interaction, lots of good questions. I learned a lot, and we'll do it again tomorrow morning at 6:30. Lynn's is going to bed, and it's late where you are. Thank you for stopping by. I appreciate you. Looking forward to seeing you in the next one, next time you're available. Liz, nice to meet you. Yeah, I must not have seen it. There's a lot of comments coming through. No, I don't do anything mushrooms, man. I don't mess with mushrooms. You just joshing you. Hey, what's going on? I see what you did, Mishy. I see what you did there. Clever. Well played. Well played. Crafted Moments. Thanks for the Panther Paws. I appreciate that. About ready to wrap things up here. I got to go get a little something to eat and have another cup of coffee and see if my kids are up. They're off, so like they don't have to be up, but I bet they are. Probable. Thank you. I'm glad you enjoyed the live. I enjoy doing them. I like learning things, talking to people. So I hope to see you in the next one. How do you get notifications when I go live? So when I usually schedule them out. Like, so when I get off of here, I'll schedule the next one for tomorrow morning, and then you can register for it. I don't know if there's a way to sign up for that. Now, if you follow me over here on this one, because that one actually will send you an email when I schedule a live, and then it'll remind you when I do go live. It'll say this person's going live. So yes, I think there is a way to do that in TikTok. I think you have to register for it, but that means I have to create it. So once I create it, I think you can register for it. So, but yeah, I mean, pretty much every weekday morning at 6:30, and on the weekends, if I get enough sleep, if we have a late movie night with the kids, then I might sleep in. But if we go to bed at a decent hour, I'll get up and do a live on the weekends as well. So yes. All right. That music means I'm signing out. Thank you all so much. It was a wonderful live, over 2,000 unique viewers, 75 new followers, lots of wonderful questions, some new friends. I will try to follow many of you back. Until then, be kind to yourself, be kind to others, prioritize your mental health. I'm Gary, the ER nurse, and we'll see you tomorrow morning.